in West Bengal and in India. So just go for a description. What is the incidence of COVID-19? What is the prevalence of COVID-19? What is the attack rate of COVID-19? That is the part of the observational studies. We are not using some drugs. We are not testing some vaccines for COVID-19, which will come under experiment. So if you classify study design into observational and experimental one, under observational, we have descriptive studies and analytical studies. For experimental, we have animal experiment and human interventional experiment, like Covishield vaccine now currently experimented in UK and also in India on COVID on volunteers for COVID-19. That is a human interventional experiment. That's another thing. So what we have descriptive and we have analytical studies. For descriptive, we have case report, case series, cross-sectional and ecological study. For analytical, we have cohort and case control study. So for your purpose, what is your thesis description? It is descriptive cross-sectional studies done in Arjikar Medical College over the 18 months. That is your thesis guideline. So to the outline, cross-sectional study and ecological study. Cross-sectional studies include surveys. People are studied at a point in time without any follow-up. So actually what you are doing in your thesis, you are studying a particular disease in a particular time. You are not following. That is your cross-sectional study. And that can combine with follow-up to create a cohort study. And we can conduct repeated cross-sectional studies to measure the change in population. So we can study a particular disease in 1900 here. We can study the same disease in 1910. We can study the same disease in 1950. We can study the same disease in 2020. So we can study same cross-sectional study over the year to measure the change in a population. Number of uninsured Americans rises to 50.7 million. USA data, 9/17 September 2010, that is taken from the data from Census Bureau. In 2007 to 2008, almost 1 in 5 children older than 5 years was obese. That is in the Health United States 2010 data from National Health and Nutrition Examination Survey. 35% of the birth to US women during the preceding 5 years were mistimed or unwanted. 2002 National Survey of Family Growth, Series 23, number 25, table number 1. That is source is nothing but a CDC. So, what we are getting from these studies, we are not getting this incidence information. We are getting a prevalence information from this study. Sometimes can reconstruct incidence from historical information. For example, the incidence proportion of quitting smoking, called the quit ratio, we can study from a cross-sectional study how many people are ex-smokers, how many people are ever smokers. So we can give a ratio, that is called the quit ratio of smoking in case of ex-smokers and ever smokers, that can be calculated from the survey data. So what we are measuring? We are measuring a still life, a snapshot of a population of a particular region, particular country or particular state, that is in a point in time, or particular hospital, one department of hospital. So all the patients of department of surgery, we are going for a cross-sectional study that is a snapshot over the year of 1.5 years. So you can measure the attitude, we can measure the belief, we can measure the behavior, personal family history, drug history, existing or past health condition, anything else that doesn't require follow-up to assess. The source of most of which we know about the population. So it's a census data that is applicable to a whole country. That is nothing but the largest cross-sectional study of entire population that is done every 10 years in our country. So there are several national surveys that is conducted by NCHS, National Health Interview Survey, household interviews, National Health Nutrition Examination Survey, interviews and physical examination, National Survey of Family Growth, household interviews, National Health Care Survey by medical records. So you can go for different surveys. We can go from our archived BSTs, that is bedded ticket. We can construct a cross-sectional survey of one patient in our own hospital. So national surveys are nothing but designed to be representative of the entire country. That is Moresky, household interview, telephone call, and email. Employ complex sampling designs to optimize efficiency, trade-off between information and cost. So household interview is a bit costly than a simple telephone call or simple mail. So it's a between the trade-off between the information and the cost. There is a logistically challenging, answering machines, cell phones, whatever you need for that survey, worldwide, all over the population survey, that's important. So, for example, National Health Interview Survey, NHSIS, conducted every year in US by National Center for Health Statistics, that is by CDC. Statistic multi-stage household survey that covers a civilian non-institutionalized population of the United States, and that is designed every decade to use new sensors. That can also be multi-staged. How it is multi-staged? Improve logistical feasibility and reduces cost. So reduces precision. So whole of the countries can be divided into several primary sampling units. So primary sampling unit, nothing but metropolitan statistical area, that may be county, group of adjacent counties, like that. So from each primary sampling unit, you can sample a small number of population that is representative of the particular primary sampling units. So within a country, we sample a primary sampling unit. From a primary sampling unit, we take some representative sample population. That is called a multi-stage sampling. Select sample of census block groups within each selected PSU. Map each selected census block group or examine building permits. Select one cluster of 4 to 8 housing units dispersed evenly throughout the block, and you can draw the sample. We can do a stratified sampling, which is divided into 1900 PSU. That is public sector sampling unit. Largest 52 PSUs are self-representing, and rest of the PSUs divided into 73 categories. Depending on the socioeconomic, demographic, and political variable. Actually, this PSU term has been done for the political purpose between the Democrats and Republicans of US. Ultimately, they use this PSU term for the health census data later on. So sampling size, if maybe it is 100, maybe 400, maybe 900, maybe 1600, we can consider a 95% lower limit or upper 95% limit. So it can be done later on. So stratified also place census blocks into categories and sample within each block, and oversample may be done from strata. So what is defined population? Studies, especially cross-sectional study, are easiest to interpret when they are based on a population that has some existence apart from study itself. That is for defined population. So political subdivision or institutional. So one doctor, one farmer, one school teacher, and one grocery, that cannot be considered as a defined population. So one defined population is nothing but all the postgraduate trainees of first year of Arjikar Medical College. It's a defined population. All the faculty members of Arjikar Medical College, defined population. All the associate professors of Arjikar Medical College, defined population. You can subdivide it into all the faculty members of cardiovascular system is a subdivision of a defined population. So surface of central Indian population is the largest survey done in 1993. HIV seroprevalence survey in the 3 counties, STD clinics in central NC in 1988. 3,000 anonymous unlinked leftover sera were taken for consideration. Anonymous questionnaire for demographic and risk factors are taken into account, and they are grouped: homosexual males 46%, bisexual 25%, heterosexual 1.6%, women 0.6%, total 2.56%, heterosexual men and women. So they have some characteristic features of prevalence by risk factors. Syphilis has got the highest risk factor than gonorrhea or other things. So interpretation, maybe it's an interpretation of the cross-sectional studies. It actually measured a prevalence. If incidence is our real interest, prevalence is often not a good surrogate marker. Studies only survivors and stayers may be difficult to determine whether the cause came before an effect. For example, some disease, say smoking is related to lung cancer. So we studied a group of lung cancer patients. In them, we found that most of them are smokers. They have lung cancers, but we cannot define, we cannot link up between the smoking and lung cancer because we are taking consideration just 1 month in time. That is a snapshot of their population. So can choose by exposure and overall, can choose by disease, may not be distinguished from case control study with prevalent cases. So advantages of cross-sectional studies are nothing but good design for hypothesis generation, can estimate overall specific disease prevalence and sometimes rates, can estimate exposure proportion in the population, can study multiple exposure or multiple outcomes or disease, and relatively easy, quick, inexpensive, no issue of subjecting any animals or producers to particular treatment, best suited to studying permanent factors, that is breed, sex, blood types, often good first step for new study issues. There are several disadvantages. It is very much impractical for rare disease, not a useful type of study for establishing causal relationship, confounding, sometimes difficult to control, no control over sample size for each exposure by disease subclass. That may be problems with temporal sequence of data, hard to decide when disease would actually occur. Disease may occur the exposure, miss disease still in the latent period, recall our previous exposure may be faulty. For example, COVID-19 situation, we are missing many disease in asymptomatic phase because we are not following the particular patient or particular cases. So you start with a defined population, you gather data on exposure and disease. There may be 4 categories are possible: exposed have disease, exposed do not have disease, not exposed have disease, not exposed do not have disease. So we define a population, determine the presence and absence of exposure and presence or absence of disease for each individual. Each subject then can be categorized into of the 4 possible subgroups. So 2x2 contingency table can be constructed from your data on exposure and disease, and calculation can be done from there on. So we have a 2x2 contingency table. We have exposed on one side and non-exposed on one side, exposure, and disease on the upper one. So A, B, and C by D. So we can calculate the prevalence, that is diseased by A plus A and A plus B, exposed condition, versus compared to non-exposed person, C by C plus D. We can calculate prevalence of exposure in disease condition like A by C, because disease condition can be in exposed, also in causes in the non-exposed person, and there will be may not be any disease on the exposed, or may not be any disease in neither one. So B by B plus D. Just simple calculation can be done from the study. So there are biases. There are high quality cross-sectional studies are not easy to conduct, as they are susceptible to all three common causes of biases, of which selection bias and selection bias are prime concern. Obtaining a representative sample is crucial, but no easy task. One should have a full list of eligible subjects, and sample is picked using simple random sampling, with every subject standing an equal chance of being included. That is very difficult to perform in real scenario, because you are doing a thesis work on a 51 sample size, and you have a very short time, 18 months of study of this particular thesis. You are not getting as much as cases throughout your year. So ultimately, you are taking all the samples. That's why very difficult to control the selection bias. So unlike studies starting from a series of patients, that is often the need to select a sample of subject from a pool study population that can be very large. Multi-stage sampling and systematic sampling with caution can sometimes achieve the goal of having a representative sample, but that is very difficult to perform in real scenario. Unfortunately, samples are sometimes picked up by convenience, being handy, or misleadingly reported as being random sample that we are doing for a thesis. Next one is information bias. In cross-sectional studies, information on risk factors and health conditions, that is outcomes as well as other factors, is often obtained at the same time point. Self-reporting, answering a questionnaire, or responding, agreeing to an interview, sometimes happen. Sometimes we give the patient, sometimes we give yes or no. Patient will always say yes. Third is confounding. A pure prevalence study does not examine causal relationship. So hence confounding should not be one important thing for a core study or case control study, but not for prevalence study. Alternatively, health indicators in various subgroups are compared. In under circumstances, possible confounding by. Last one of your important part is STROBE guideline or STROBE statement for reporting observational studies. STROBE means strengthening the reporting of observational studies in epidemiology. The aim of this STROBE guideline was to provide the readily available checklist to ensure a clear representation of what was planned and conducted in an observational study. A checklist of items that should be included in reports of observational studies, and you must report the page number in your manuscript where you consider each of the items listed in the checklist. So AIM's intention is solely to provide guidance on how to report observational research well. For you, STROBE guide statements is very important to write a synopsis. How? Also, while clarity of the reporting is prerequisite to evaluation, the checklist is not an instrument to evaluate the quality of observational research. STROBE is developed in 2004 in Manchester by 23 different institutes along with different journals, editors of different journals. And STROBE statement can be found without any cost in many journals. You can download that STROBE statement in what format you can use for your synopsis. So what is that? It's a checklist of 22 items. The first item is item number 1, title and abstract. Under it, that is subsection A and B. Indicate the study design with commonly used term and title in this abstract. Provide in the abstract informative and balanced summary what has done, what has found. Number 2 and 3, background rationale for your study. Explain the scientific background rationale for the investigation being reported. Objective, state specific objectives, including any pre-specified hypothesis. 4, that is your study design, descriptive, cross-sectional study, study setting, location, relevant dates, period recruitment, exposure, follow-up, data collection. Participant, core study, or cross-sectional study, or case conclude study. You have to mention that. Variables ki kiya ache. What are the variables? Number 7 point. Clearly define all outcomes, exposure, predictors, potential confounders and effects modifiers. Give diagnostic criteria if applicable. Data source or measurement for each variable of interest. Give sources of data and details of methods of assessment, measurement. Number 9, you have to include bias. What is the bias of your study? Describe any effort to address potential source of bias. You can talk to your guide to check the bias. Study sample size. You have to mention study sample size. What is the 41 cases, 52 cases, depending on your study setting. What is the study quantitative variables are there? What is the statistical method we are going to apply? Results. Number 13, 14, and 15. Who are the participants? What is your descriptive data? And what is your outcome data? Everything can be pointed out in a synopsis or a thesis. So item number 16 is the main result. Then you give a analysis. Discussion, key result, your limitation, interpretation of your thesis data, generalizability of your thesis, and other information like funding. If it is a self-funding, you mention a self-funding. If it is done by outside, and give your outside data. So for your thesis, it is always self-funding. It is done by the Department of Pathology or Surgery or Medicine with help of the RGK Medical College and hospitals, like that. So with this view, we are ending the session on cross-sectional study. We can take a 2-minute recess.
If anybody has some questions, please write in the chat box. There is a 2-minute recess, so your questions will be answered by the facilitator duly.
You measure exposure or status. You divide them exposed and non-exposed, and you give a time, either a backward time or a backward time, and you follow direction of inquiry in the forward time. So what is design? There are some cases, there are some controls. So the cases have given a history of exposure. Some may not give an history of exposure, and controls, they may have some exposure, may not have some exposure. So what the hallmark of case control study? From cases and controls and searchers for exposure. We are searching exposure from the cases and from the control. So your case is nothing but a cancer patient. So you have some cancer patient, you have some control group. So cancer patients or control groups are compared, they can be compared. That is 60 years of male patient of cancer, 60 years of male of control. You cannot give 60 years of male patient of cancer to 10 years of babies or children of control group. You can control, you can compare them. So in similar way, look into their history, past history. Also, you can study control group in their past. You take one or two important points. That is, look the history of smoking in lung cancer in the past. You identify smoking as a risk factor. You compare in cancer patient, also in control patient. So it's a case control study is defined as an epidemiological approach in which researchers starts by picking up cases who have already developed particular disease or outcome of interest and comparison group or control who have not developed the disease but are similar to cases. Then he tries to find out the presence of particular exposure which he or she thinks it's a risk factor and compares the two groups in regard to presence or history of exposure. So case, a person in the population or study group identified as having the particular disease, health disorder or condition under investigation, or control, person in the comparison group that differs in disease experience or other health related outcomes is not having the outcome being studied. So advantage, easy to carry out, rapid, inexpensive, rare disease investigation can be done. There is no risk to the subject. You are taking the history, only history. You are not intervening. Allow study the several etiological factors. You can study smoking, you can study sugar abuse, you can study increased fat, you can study any number of conditions, any number of risk factors for a cancer patient in the past. Because there's a rational prevention and control measures can be taken. There will be no attrition because we are just doing his history, taking his history. Minimal ethical problem because we are not intervening. Disadvantage, it has got bias. Control selection is very difficult. Incidence cannot be measured, cannot differentiate between causes and associated factors. Not if suitable for evaluation of therapy, representative of cases and controls may not be equal. So features, both exposure and outcome has happened before the start of the study. So you are talking about a cancer patient. Cancer has already been developed. You are comparing with the population of non-cancer patient whom the cancer has not developed. The study proceeds backwards from effect to cause. It uses the comparison group to support or refute an inference. Design of a case control study is similar to cross-sectional study. That is 22 contingency table. You first select the cases with disease or control without disease. Then measure the past exposure, were exposed to smoking. Some of them are not exposed to smoking. Then proportion exposed and proportion not exposed. Step, selection cases and control, matching, measurement of exposure, analysis and interpretation. Selection of cases and controls. Selection of definition of a case. You have to select a diagnostic criteria, maybe from a single hospital, maybe from a network of different hospitals of different states of India. And there are some eligibility criteria, incident cases, but there may be some prevalent cases you can check. Sources of cases, maybe hospital, maybe from general population. It's your choice. Selection of control must be free from disease under study, must be similar to the cases except for the free from cancer or diabetes or whatever we are the most difficult. Sources of control may be from the same hospital, maybe from the relatives of the patient, from the neighborhood of the patient, or from the general population. So advantage, and disadvantage of hospital-based sources, easily identified, available for interview, more willing no to cooperate, tend to give complete and accurate information. Recall bias is decreased. What a disadvantage not typical of general population. Causes more risk factors for disease. So one hospital case and one hospital control, that hospital control may have some other disease. So that was for the risk factor for other disease. Some diseases may share risk factors with disease under study, whom to exclude. That may be we call the Boxonian bias. Population-based, there is registry cases, most representative of the general population and general healthy. They are usually general healthy. What is the problem? Time, money, and energy of the interviewer. Opportunity of exposure may not be same as that of the cases. So this controls may not be in the same location or may not be in the same occupation. Neighborhood controls or telephone exchange, random dialing controls are cases similar in residence, easier than sampling the population. Most of them are non-cooperative. There may be some security issues, and that they are all obviously not representative of the general population. Best friend control or sibling control that are easily accessible, cooperative, similar to cases in most aspects. Sometimes they are more overmatching because siblings may have got the similar genetic makeup of that of the cases. So how many controls are needed? 1 to 1 for larger study, that may be 1 to 2, that may be 1 to 3, that may be multiple control. Failure to select appropriate control group result in bias. So multiple controls of different types are available for exploring alternate hypotheses and for taking into account possible potential bias. So children with brain tumor, children with other cancers, children without cancer. So children with brain tumor can be taken as a particular disease. Children with other cancers can be taken as another part of control. Children without any cancer taken as another part of control. We are seeking for radiation causes cancer and radiation causes brain cancer only. So multiple controls can be done in a single study. Next thing is matching. Matching is a process in which we select control in such a way that they are similar to case in all the demographical aspect with regard to certain pertinent variable, that means age, which are known to influence the outcome of disease and which, if not adequately matched for comparability, could distort or confound the result. What is a confounding factor? So we are studying esophageal cancer, we are studying smoking, and we found that some of the patients are also alcoholic. So alcoholism is a confounding factor for esophageal cancer. Matching type, we can group matching, we can go for a pair matching. Measurement of exposure. Interviews, questionnaires, past records, and hospital record or employment record. Next is analysis. So what is our idea? To find out exposure rate among cases and control to suspected factor, estimation of disease risk associated with exposure, that is odd ratio. So exposure rate, smoker less than 5 packs per day cigarette, cases 33, non-smoker, lung cancer 2, control without cancer, lung 55, non-smoker 27. So it's an example. So you format 22 contingency table, cases here 33 by 35, 94.2%, control 67%. So frequency of smoking was definitely higher among the lung cancer patient than those without cancers. So what's the odds? So odds of an event is defined as a ratio of the number of ways an event can occur to a number of ways an event cannot occur. So it's a probability of event X occurring is P, then odds of it occurring is P by 1 minus P. So odds ratio or ratio of the odds that the cases were exposed to the odds, that the controls were exposed. So odds ratio is nothing but odds the cases were exposed A by C, odds that the control were exposed, that is B by D. So ultimately A into D by B into C. Estimation of the risks, odds ratio is nothing but cross product ratio, odds that cases were exposed A by C, odds that controls were exposed B by D, or ratio in that particular example is 8.1. So it is an interpretation. So odds of smoking more than 5 cigarettes per day was 8.1 times more in the lung cancer patient than those without lung cancer. Or smoking more than 5 per day was found to be associated 8 times more in patient with lung cancer than those without lung cancer. So if you change your criteria, 10 cigarettes per day, 1 cigarettes per day, 50 cigarettes per day, you can have different odds ratio in particular lung cancer patient. So it's your trial and it's your diagnostic interpretation how we will proceed for a particular case control study. So what is the bias? Bias due to confounding, that may be selection bias, that may be healthy worker effect, memory or recall bias, Bergsonian bias, interviewer's bias. So bias due to confounding already explained in the previous session. Selection bias or inappropriate control group is most important thing. Basic dictum is control should be derived from the same source population from which the cases have come. That control should be equally at risk. So 60 years of age at lung cancer patient residing at Bonga, so you should take a control of the same age group or nearly same age group residing in the same area, doing the same business or like same occupation or like that. So that is your appropriate selection. So you know, Nakano Mank development STD clinics is the cases. Control same clinic who did not have STD, but many of the controls may not have developed STD because the partner may not have STD. So that is now called a confounding variable. Maybe healthy worker effect between the group of soldiers and the young, the older age group. You cannot compare between these two groups. Memory or recall bias. The 60 years of old age may not recall in the 20 years past. So this is a person who is diseased is most likely to remember about the exposure than the non-diseased. So X-ray exposure and congenital malformation is very difficult to find. Unprotected sexual intercourse in HIV is far more difficult to find. Bergsonian bias is hospital selective admissions. So cigarette smoking causes peptic ulcers. For triple query, high fever and febrile seizures. These are Bergsonian bias examples. So with this, we are closing case control study. We are taking 2-minute recess for a core study.
If you have any questions, please type them in the chat box. Another sir, you can start.
Hmm. So last session is on this particular observation studies cohort study. Cohort study is already also called longitudinal study or prospective study or incident study or forward-looking study. What is a cohort? It's a group of people who share a common characteristic or experience within a defined time period. Age cohort, occupation cohort, exposure to drug or vaccine cohort, pregnancy cohort, insured person cohort. Occupation cohort, all doctors of Department of Pathology is occupation cohort. Exposure to drugs or vaccine, all the volunteers taking Covishield vaccine, say vaccine cohort. All the pregnant women in the Department of Gynecology is a pregnancy cohort. All the insured persons are insured cohort. So what is a cohort? It's cohort nothing but the ancient Roman military unit comprising 6 centuries equal to 1/10 of a legion. A group of people banded together or treated as a group is called a cohort. When is the cohort study warranted? Good evidence of its association between exposure and outcome as shown by descriptive and case control studies are if there. So you can go for the cohort study. But exposure is rare, but incidence is high among exposed. But attrition of people can be minimized when ample of funds are available. Then we can go for a cohort study. It's a time-oriented study. So again, the same classification. And cohort study is just below the RCT, that is randomized control trial. It's a good evidence strength. So design, same design. Exposed, disease develop, disease does not develop. Not exposed, disease develops, and disease does not develop. So 22 contingency table. So dogma of the cohort study, healthy people. You start with a group of healthy people, that is a cohort of healthy people. You expose them to certain things. There are 2 groups, some are exposed, some are unexposed. Whom some disease occurs and some of them are not suffering from disease. You follow this cohort for a long period of time. 10 years, 15 years, 20 years, 25 years. You can remember Fleming-Hart first study is a good example of a cohort study. The longest one is going on. So there are cohort studies, some exposed cohort, some non-exposed cohort. Starting in 2000, you divide exposed group into with outcome, without outcome. In not exposed, you can divide them into with outcome, without outcome. We follow the patient, we follow every person of the cohort up to 2005, 2006, 2010, like that. So features, cohorts are identified prior to appearance of a disease under investigation. Study groups are observed over a period of time to determine the frequency of disease among them. Study proceeds forward from the cause to effect. Key element of a course study is time. So as a trainee student, you have only 18 months time. That's why you are not prepared for a course study. What you have to do is just a cross-sectional study. So following the exposed and unexposed groups over time, course studies are uniquely equipped with described process, mechanism by which exposure related to development of disease can be done. It's a primary tool to study time and medicine. They provide the data to describe when the disease occurred and track their consequences over time. Factors that can cause disease or early signs of disease can be monitored over time. Diversity of the individual in cohort study provides data to identify risk factor that makes certain individual more susceptible and certain individual less susceptible to particular risk factors that can be studied over time. Data collected in cohort studies are useful to describe the prognostic markers of exposure, and multi-site cohort studies may serve additional role of characterizing where disease occurs and to what extent of the disease is spread in different locations. So you study heart disease in US, you study cardiac disease in UK, in Europe, in India, in Asia, other parts of Asia. And you can assess between the ethnicity of the population, the different ethnic groups with same risk factors. The cohort study with adequate sample and follow-up enables us to understand natural history of a disease. So once measured or frequency of disease occurrence, incidence cases in person years is adapted, cohort studies allow the direct comparison of the risks of the becoming ill in several groups. This comparison can be relative or absolute. So relative means how many times higher or lower is the risk between exposed and unexposed, that is for relative risk. Absolute, how much difference in risk there is there between exposed and unexposed, that is attributable risk. So relative risk will give you causal relationship between the disease and exposure, and attributable risk measures the change of incidence due to exposure in question. It quantifies actually the burden of disease that exposure exert in a population. And identification of the exposure and risk factors for a disease forms basis of prevention. So cohort-based association that have resulted in prevention studies is like lung cancer and smoking, avoid cigarettes, unprotected sex and HIV, avoid IV drug and use on HIV, avoid to prevent heart disease, avoid a high LDL and low HDL level. That is from the framing heart studies. To prevent cervical cancer, avoid papillomavirus infection, and to develop papillomavirus vaccine. General consideration: cohort must be free from disease under study. Both the study and control groups should be equally susceptible to the disease under study. Both groups should be comparable in respect to all possible variables. Diagnostic and eligibility criteria of disease must be defined beforehand. So there are three types of study, cohort study. One is prospective cohort, one is retrospective cohort study, one is combination of the both retrospective and prospective cohort study. So prospective, you start with the defined population in the year 2008. You define some exposure in certain part of the time. You getting some disease in 2028. You follow up the total population for 20 years. Some component of the defined population may be lost during follow-up. So that is called the attrition. And some of the interviewers may be lost, may be died in between. So it says cohort study is actually based on a particular institute. So institute will proceed the cohort study with newer and newer interviewers and newer doctors as long as the study is going on. Retrospective study, you define population from your record on the archived BST of 1988. You follow up the cases in 2008. You studied the BST or any other archived material and take the history. You found the exposure and non-exposure of particular risk factors. And sometimes this one combination, both retrospective and prospective cohort study or a particular disease condition. For elements, same elements, selection, obtaining data on exposure, selection of comparison group, you follow up the case to analyze. Selection, general population, when exposure of death is frequent in general population, residing in well-defined geographical, political, and administrative areas, that is the Framingham Heart Study. Special group you can choose: doctors, nurses, lawyers, teachers, college alumni, employees, volunteers. Exposure group, special exposure. Selection of study subject, you start with exposed and not exposed. You follow up for a long period of time. You wait until the disease appears. Then you calculate. So obtaining data and exposure, there are some cohort members you interview, you give some questionnaires. You review the record of dose of radiation, you conduct surgery, details of medical treatment, medical examination of special cases, blood pressure, serum cholesterol, ECG, elemental surveys where the cohort lived or worked. Obtaining data and exposure can be from information about exposure will allow classification of cohort member. Number one, according to the whether or not they have exposed to suspected factor, according to the degree of exposure, at least in broad class in case of a special exposure group. So what are the elements of cohort study? Selection of comparison. Maybe internal comparison, maybe external comparison, or comparison with general population rates. Internal comparison, no outside comparison group required. A single cohort enters the study and on the basis of information obtained, classified into several comparison groups according to degree or level of exposure. So some within a single cohort with a single group of cohort population, you define some group of cohort, subgroup of cohort, taking some particular interest in taking banana, and some are taking other apples. So some group taking a banana, some group taking apples. You follow up them for 20 years. You see what happens to them. You compare the degree of exposure like that. External combination, external comparison, when information or degree of exposure is not available, smoker and non-smoker, cohort of radiologists with cohort of ophthalmologists. The study of control group cohort should be similar in the demographic and possibly inform important variables other than those under study. Comparison of general population rates, frequency of lung cancer among uranium mine workers versus frequency of lung cancer in general population. Asbestos workers versus general population cancer, like that. Examination is most important thing. You have to define in your protocol periodic medical examination every 1 month or every 6 months or every 1 year, like that. You review of their records from the physician, talk to their physician, talk to their hospitals. You routine survey of their records. You mail their questionnaire, you phone call personally, you periodic home visit, like that every all 3 years. Sometimes the cohort may be lost to follow up due to death, change of residence, migration, withdrawal of occupation, like that. So achieve 95% follow up as much as possible. So there may be 5% lost to follow up, maybe as applicable. So analysis. What is analysis? What you're getting from the study, you're getting incidence rate among exposed, among not exposed. You are getting the risk. You are getting relative risk. You are getting attributable risk. You are getting population attributable risk. So same stable, 22 continuous table incidence among exposed, incidence among non-exposed. So relative risk. Relative risk is a ratio between the incidence among exposed, that means A by A plus B among exposed, A by A plus B, incidence among not exposed, C by C plus D. Also cause, next is attributable risk, also risk difference, already told. It is the incidence among rate among exposed minus incidence of disease rate among non-exposed. So incidence of disease rate among exposed, incidence of disease among non-exposed by incidence of disease among exposed into 100. This is the amount of disease that might be eliminated is if the risk factor on the study is controlled or eliminated. That is attributable risk. So if you have certain patient with smokers who develop chronic heart disease, there are some 84 or some data is there. So incidence among exposed minus incidence among non-exposed is a risk difference. Your risk difference is 28.0 to 17.4, that is 10.6 by 1,000 population. So attributable risk, 10.6 of the 28 by 1,000 incidence cases of CSD are attributed to the fact these people smoke. Among smokers, 10.6 of the 28 by 1,000 incidence cases of CSD that occurred could be prevented if smoking were eliminated. So attributable risk percentage. So incidence among exposed minus incidence among not exposed by incidence among exposed is equal to etiological fraction. So 28 minus 17 by 28 is 37.9%. So what is your interpretation? Among smokers, almost 38 points of comorbidity from CSD may be attributable from smoking. Similarly, in other words, you can say among smokers, 35% of the morbidity from CSD could be prevented if smoking was eliminated. Next one is population attributable risk. Among exposed and non-exposed, that is the population. How much of the disease that occurred can be attributed to a certain exposure? Can be explained by PAR and PAR's percentage. This is of interest to policymakers and those responsible for funding prevention program. So based on population attributable risk, ICMR or whatever those government body is that, they can generate some funding program or they can give some policy to prevent those particular cases. For example, we want to estimate how much of the burden of diabetes among Tampanians is attributed to obesity. So, first, in order to calculate the PR percentage, we have to be reasonably sure that the result of the study can be generalized to the population of Tampa. So, you have to choose your case, your cohort very carefully. So, incidence rates drawn from the sample approximate the incidence rate in the entire population. That is a missing. So, if you go for if you have a selection bias, your total study will be failed. So, population exposure attributable risk, I total incidence among total minus incidence among non-exposed. So, obese patient, slim patient, 850 and 250, diabetes, yes, to 850, no, 3,650, total case 10,000. So, incidence among total is 1100 by 10,000, that is 110 by 10,000. Incidence among not exposed, 250 by 550, 45.5 by 1000. So PAR, it is 64.5 by 1000. So in Tampa, 64.5 of the 100 attributed to obesity. It's a huge number. In Tampa, 64.5 of the incidents can be prevented with sufficient weight loss. What is the government outline for the policy making decision is to reduce weight. So PAR percent, I total minus I non-exposed by I total. So 110 minus 45.5 by 110 into 100, that is 58.6%. What is the relative risk versus attributable risk? The size of the RR is a better index than AR for assessing the etiological role of a factor in this disease. Larger the year, stronger the association between the cause and effect as exemplified in previous equations. AR gives better idea on impact of successful preventive or public health program might have in reducing the problem. Advantage of a case study, incidence can be calculated. Several outcomes can be studied simultaneously. Provide direct estimate of relative risk. Dose response ratio can be calculated. Certain bias can be minimized. Disadvantage involves large number of people and unsuitable for study of disease with very low incidence, like genetic disease. Takes long time to conduct the study. There will be loss of staff, loss of fund with loss of years like that. Requires extensive record keeping. And sometimes the most of the population are lost to follow up. Selection of comparison group is very difficult. It is very expensive. Study may alter the participants' behavior, and there will be some ethical problems. So there are some difference between case control and case study. Case control is effect to cause, cohort cause to effect. Case control starts with the disease. Cohort starts with exposure. Case control tests whether suspected cause is more frequent among disease or undiseased. Test whether suspected disease require more frequently among exposed or not exposed. Case control is fewer subject, cohort a larger number of subject. It gives a quick result. Cohort gives a long follow-up, suitable for rare disease, suitable for rare exposures. It is odds ratio, gives the odds ratio. It gives relative risk or attributable risk. It's relatively cheap and relatively expensive. So with this, we are concluding our case control and cohort study. Thank you.
Thank you, Anadi sir, for an excellent presentation. It will be most helpful to the students. I'll now ask if anyone of you have got some questions to ask sir directly. You can chat, write in chat box.